The adrenals. Commonly overlooked, belittled, likened to the mere hat of the kidney. Well, the adrenals make up around 10 grams of some of the most important tissue in the entire body. So pay attention. These organs house the production lines of some of the most essential hormones in the body, which leads to a myriad of pathologies when any of the lines are under or overproductive. In this sketch, we'll take a look at some of the common and more rare causes of underproduction of adrenal hormones and their clinical consequences. Adrenal insufficiency. And since we're talking about hormone production going awry, this sketch is going to take place on a set, where a movie production is getting out of hand. First, let's go back to the turn of the 20th century. The motion picture industry of New Jersey is being oppressively sued by the Edison Company for patent violation. Exasperated directors and producers looking for artistic freedom begin to flee far west, to the desert of California. They find a new town, totally off the radar, called Hollywood. Within 20 years, multiple major motion picture companies called this desert oasis home, and film production had grown to one of America's largest industries. With the end of the silent era of film and the overnight financial success of Hollywood, American film entered its golden age. The biggest production company in town? Cortical Studios. The structure and function of the adrenals is conveniently divided into the outer cortex candy shell and the creamy nougat medulla. It's the outer cortex we'll be focusing on today, embodied by the archway leading to the production lot. The outer layer, so the top of the arch, is the zona glomerulosa, which is responsible for mineralocorticoid production. The main mineralocorticoid is aldosterone, symbolized by our recurring mineralocorticoid mineral crystal. The middle layer is the zona fasciculata, which makes cortisol, embodied as usual by that eerie moon face, reminiscent of the classic moon phases that can occur with steroid excess. And lastly, the innermost zona reticularis, which produces androgens, hence the man symbol across the walkway there. As with most endocrine disorders, the underlying pathology can occur at various points along the hormone production pathway. Primary adrenal insufficiency is due to intrinsic failure of the adrenal glands. Secondary adrenal insufficiency occurs with normal adrenals, but no ACTH stimulation from the pituitary. Finally, tertiary adrenal insufficiency is caused by deficient CRH release from the hypothalamus. Disease anywhere along this path can lead to clinical adrenal insufficiency. Let's head over to set 1, where we'll reenact the horror and wonder of primary adrenal insufficiency. Primary, remember, means that it's the adrenals themselves that are busted. It can present in both acute and, more commonly, chronic forms. That adrenal-shaped beanie will be our recurring symbol for the adrenal gland, by the way. Guess they're setting up for some kind of science fiction flick? While there are several causes of primary adrenal insufficiency, the underlying pathology is the same. Dysfunction of the layers of the adrenal cortex leading to a lack of aldosterone, cortisol, and less importantly, androgens. A relatively uncommon cause of acute primary adrenal insufficiency is bilateral adrenal hemorrhage. This occurs most commonly in anticoagulated patients, though it can also occur in the setting of DIC, when you're losing all those clotting factors. Paradoxically, adrenal hemorrhage can be caused by adrenal vein thrombosis, which might occur in hypercoagulable states or with malignancy. A unique form of bilateral adrenal hemorrhage is Waterhouse-Friderichsen syndrome, which presents with bilateral adrenal hemorrhage in the setting of acute sepsis, while disseminated Neisseria meningitidis infection is most commonly implicated. It can occur with any pathogen causing sepsis. The exact mechanism isn't fully understood, but it's possible that sepsis causes a state of massively increased blood flow through the adrenals due to acute stress, in combination with a bleeding diathesis. Again, think of DIC, when all those clotting factors are spent. In the end, the adrenals hemorrhage enough to cause acute adrenal failure. An acute precipitous decline in adrenal function is dubbed adrenal crisis, the signs and symptoms of which are largely due to sudden lack of cortisol production from the zona reticularis. Yup. That is a ridiculously huge glucocorticoid moon face in the back, with a rocket ship lodged in its eye socket. And it's here to remind you of a profound and acute loss of cortisol function. Not good, because cortisol exerts numerous important effects throughout the body. Decreased cortisol can manifest, at least in the early stages, as nausea, abdominal pain, weakness, and fatigue. It's almost like your patient has a really bad stomach flu. It gets far worse, however. In the vasculature, cortisol upregulates alpha-1 receptor expression in arterioles, while also increasing the sensitivity of vessels to the effects of epinephrine and norepinephrine. So a loss of cortisol means a loss of vascular tone. See how dilated those red arterial sleeves are? What can follow is hypotension and shock. Cortisol normally counteracts the effects of insulin and stimulates gluconeogenesis, so a deficiency can also lead to hypoglycemia, as depicted by the scattered glucose candies. Now, don't forget about the mineralocorticoids. When you lose the whole cortex of the adrenal gland, aldosterone goes down too, as illustrated by that crushed mineralocorticoid mineral crystal. In the healthy adrenal, the renin-angiotensin II cascade stimulates the release of aldosterone from the zona glomerulosa. Aldosterone then goes to work at the renal collecting duct, facilitating sodium reabsorption and potassium excretion. So, as you'd expect, in the setting of acute adrenal failure, you'll see the opposite. A loss of aldosterone function leads to the classic triad of hyponatremia, hyperkalemia, and non-anion gap metabolic acidosis. Hyperkalemia occurs due to decreased activity of sodium-potassium countertransporters in the collecting ducts of nephrons, which are usually stimulated by aldosterone. The acidosis part goes hand in hand with the hyperkalemia, by the way. But for now, just imagine that lots of potassium in the extracellular compartment causes an electrolyte shift. All that extra potassium moves into cells, while sodium and hydrogen ions move outside. In the nephron, when H+ moves out of the tubular cells, this actually causes an intracellular alkalosis and reduced ammonia production. Yeah, it's a little weird. Technically, this mechanism is considered a type 4 renal tubular acidosis, which is why the spaceship is made of 4 acid tubes. We'll bring it up again in the renal tubular acidosis sketch. And the third part of the triad, hyponatremia. Aldosterone normally works to activate ENAC channels and absorb sodium at the tubule. No aldosterone? It's time to dump sodium. See all those salty sodium peanuts falling to the floor? Whoa. Where are you going? We're not done here. I said the kidney is dumping sodium. I didn't say anything about hyponatremia. When the kidney moves sodium at the collecting duct, it does so in an isotonic manner. That means we are not changing the concentration of sodium left behind in the body. In other words, the renin-angiotensin-aldosterone system helps the kidney absorb and excrete more sodium, thereby absorbing and excreting more volume. This is how we manage the body's overall volume status, not osmolality. So back to adrenal insufficiency. We are dropping sodium here because we have no aldosterone, and therefore are losing volume. How do we get hyponatremic? For that part of the equation, we need to recite the mantra of the kidney. Say it with me. The kidney shifts sodium in order to... Whoa, stop. That was grating. Better yet, just listen carefully. The kidney shifts sodium in order to... Okay, get that guy out of here.
The kidney shifts sodium in order to volume. It's sodium. It's volume. It's sodium. They can't put together.
All right. Listen up. The mantra of the kidney. The kidney shifts sodium to shift volume. The kidney shifts water to shift osmolality. This is where ADH comes in, symbolized by that ADH water cooler flying in the air. In the setting of hypovolemia caused by all that sodium excretion, the hypothalamus is activated and tells the posterior pituitary to release antidiuretic hormone, or ADH. ADH works at the renal collecting duct by activating aquaporins and absorbing free water. This helps combat hypovolemia. Sounds helpful, bringing that water inside. But by absorbing water, we dilute the solutes in the serum, which will decrease osmolality and promote hyponatremia. There you go. Remember the full clinical picture here. Over on the other side of the stage, we've got low cortisol and hypotension. Cortisol normally feeds back on the hypothalamus to decrease ADH release, actually. So when cortisol is diminished, like so, we have yet another reason for increased ADH release: absorbing free water and driving hyponatremia. Okay, that was the acute version of the story, with hypotension and shock. And that moon face was kind of staring us down the whole time, like Majora's Mask style. Quickly turned into a horror movie. How about more of a suspense thriller, starring Daisy Addison? Addison's disease is a primary adrenal insufficiency with a chronic course and more insidious onset, hence our recurring chronic grandfather clock. In the developed world, Addison's disease is usually caused by autoimmune destruction of the adrenal cortex, so we've incorporated some antibody shapes into her studio chair. As with other autoimmune diseases, patients are most commonly female. There's also an association with HLA antigens DR3, DR4, and B8. See them in the sign there? HLA antigens DR3, DR4, and B8. In most cases, there are identifiable autoantibodies against enzymes found in all three layers of the adrenal cortex. This leads to slow destruction of the glands and decreased adrenal function, making onset of the classic symptoms progressive and sometimes difficult to identify. Not only that, over half of patients with Addison's disease will have dysfunction of another endocrine organ, causing type 1 diabetes mellitus, hypothyroidism, hypoparathyroidism, all kinds of stuff. Another cause of chronic primary adrenal insufficiency, and this is an interesting one, tuberculosis, symbolized, as usual, by pulmonary cacti with those classic TB cavitary lesions. And when I say TB, you say lungs. While this is the right train of thought 99% of the time, disseminated TB invading and destroying the adrenals is actually the most common cause of primary adrenal insufficiency worldwide, mostly in underdeveloped countries where TB infection is endemic. Other possible causes of primary adrenal disease include metastatic cancer, especially from the lung and breast, and a variety of disseminated infections. Back to the autoimmune version of the story. Most cases of Addison's disease start with vague, general symptoms such as fatigue, weight loss, and intermittent abdominal and joint pain. However, as destruction of the adrenals progresses, so do symptoms. Just like in acute adrenal insufficiency, we're dealing with diminished cortisol, leading to decreased vascular tone, which can lead to postural hypotension and dizziness. And on the other side, aldosterone levels fall, which promotes salt wasting. As we discussed earlier, that means volume depletion. Postural hypotension from decreased vascular tone is evoked by her kinda unconscious demeanor there, while hypovolemia from salt wasting will be symbolized by her cup of water falling as she dozes off. Salt and sugar cravings are common, though clinically significant hypoglycemia is uncommon. A characteristic finding in long-standing Addison's disease is hyperpigmentation of the skin, especially the oral mucosa, face, dorsal surface of the hands, and genitalia. You see, in response to decreased cortisol levels, your hypothalamus upregulates corticotropin hormone-releasing hormone. And this tells the pituitary to produce a bunch of adrenocorticotropic hormone. ACTH, that is. Think of it as your body yelling at your adrenal gland, trying, in vain, to wake it up. Come on, show's about to start, people. The production of ACTH involves a precursor molecule called propiomelaanocortin, or POMC, symbolized in this scene by the POMC palm tree. POMC is cleaved into active ACTH in addition to melanocyte-stimulating hormone. So while we're ramping up ACTH production in the setting of adrenal insufficiency, we're also indirectly pumping out MSH, stimulating melanocytes and causing hyperpigmentation. Females may also have changes consistent with androgen deficiency, such as decreased pubic hair and decreased libido. That's right, don't forget about the zona reticularis of the adrenal cortex. That's failing too, resulting in decreased androgen production. Up to 25% of premenopausal women may experience irregular menses or amenorrhea, though the mechanism behind both may be a combination of autoimmune primary ovarian insufficiency, malnutrition, weight loss, and chronic disease. Luckily, laboratory findings in Addison's disease are much less vague than clinical symptoms. Right out of the gate, expect a high ACTH with low cortisol, which is pathognomonic of primary adrenal insufficiency in general. At Sketchy, that means a raised ACTH clapperboard.
And action.
Remember, all that ACTH is the pituitary's way of yelling at the dysfunctional adrenals, trying to wake them up. Over on the second stage, let's quickly illustrate secondary adrenal insufficiency, which is exactly what it sounds like. Dysfunction of the adrenals secondary to another process. In this case, that process is pituitary dysfunction. See how the pituitary punching bag is getting bashed? When the pituitary is pooped, either because of a tumor or autoimmune process, for example, down goes ACTH secretion. At the level of the adrenals, that means diminished cortisol production.
Brayden, come here.
Decreased ACTH is symbolized by the director snapped ACTH clapperboard.
Here you are, wasting time, pawing at it like a walrus trying to work a doorknob. I cannot take
Wow,
this
that is getting
anymore.
heated. Okay, so decreased ACTH is one of the ways we can differentiate secondary adrenal insufficiency from primary. What are some other clues? Well, when the pituitary ain't working and ACTH is low, don't expect to see hyperpigmentation. That only occurs when ACTH is upregulated, indirectly increasing MSH levels in the process. What else? How about hyperkalemia? In primary adrenal insufficiency, destruction of the entire adrenal cortex leads to decreased aldosterone and therefore potassium retention. Turns out that if the pituitary is at fault and all you're doing is decreasing the amount of ACTH that reaches the adrenal, mineralocorticoid production from the zona glomerulosa should continue, as depicted by the mineral crystal held by the extra in the back there. Think of it as preserved mineralocorticoid function. No hyperkalemia here. One more little hint that this whole problem is coming from the pituitary gland and not from the adrenals themselves. It's rare for an injured pituitary to cause an isolated ACTH deficiency, so look for other hormones to diminish as well. That means LH and FSH deficiency causing hypogonadism, TSH deficiency causing hypothyroidism. The hormones are just all out of whack. All right, moving further up the hypothalamus pituitary adrenal axis is tertiary adrenal insufficiency, which is caused by a lack of corticotropin releasing hormone release, or CRH, from the hypothalamus. Yep, we're going all the way up to the top, to the producer. So we're inhibiting the hypothalamus here, which can be caused by brain tumors or infiltrative disease or cranial radiation. You know, brain stuff. The most common cause of tertiary adrenal insufficiency, however, is chronic steroid therapy. That's right, too many steroids. Just like that big glucocorticoid moonface crushing the producer. A prolonged course of steroids exerts chronic negative feedback on the hypothalamus and suppresses CRH release, which in turn leads to decreased ACTH from the pituitary, as evidenced by that broken clapperboard. And after that, cortisol production from the adrenals diminishes. In fact, with the chronic absence of ACTH stimulation, the adrenals slow down and even atrophy, symbolized here by the fallen adrenal cap. Nevertheless, aldosterone production by the zona glomerulosa is usually normal. See how the producer is preserving his mineralocorticoid mineral necklace, keeping it from getting crushed? Even in the face of decreased ACTH stimulation and adrenal atrophy, the renin-angiotensin-aldosterone system keeps doing its thing. Angiotensin activates aldosterone release without a problem. All right, take a look in the back of the scene, and you'll see the damage that huge rolling moon prop left in its wake. You see, when a patient is on a chronic steroid regimen, all those exogenous glucocorticoids floating around in their circulation are compensating for the lack of cortisol. It's when you discontinue their steroid that adrenal insufficiency sets in. When stopping a prolonged steroid regimen, the medication isn't immediately discontinued. Instead, it's slowly tapered off, as depicted by that long tapered flag. This gives the hypothalamus pituitary adrenal axis time to wake back up. All right. One last look around the scene before we wrap up here. Earlier in the sketch, we briefly discussed the idea of adrenal crisis, highlighting specifically acute adrenal dysfunction in the setting of something like a hemorrhaging adrenal gland. Abrupt cortisol leads to hypotension and shock. Well, I just want to emphasize here that all the causes of adrenal insufficiency illustrated in this sketch can lead to adrenal crisis if you give it the chance. Certain pituitary disorders, such as pituitary apoplexy, for example, can cause an acute reduction in ACTH, which quickly leads to cortisol deficiency and adrenal crisis. Keep the more chronic disorders in mind too, however. In the setting of undiagnosed Addison's disease, for instance, which involves chronic autoimmune destruction of the adrenals, the disease onset can be pretty insidious. The patient may be getting by with okay-ish adrenals, and it's not until a stress event, such as a serious infection or surgery, that the already fatigued adrenals just can't bump up the cortisol in time, and the patient goes into adrenal crisis mode. The same goes for any patient on long-term steroid treatment. Day to day, they should feel fine if their regimen is adequately compensating for their cortisol deficiency. When a stress event occurs, however, it's up to the clinician to increase their steroid dose in time and get the body stress ready. Otherwise, their daily regimen just won't be enough, and the balance is tipped toward adrenal crisis. So take a look at the sign. Infection? Injury? Watch out for adrenal crisis. This includes chronic primary adrenal insufficiency when the adrenals are just too weak to increase cortisol during a stress event, or patients receiving long-term steroid treatment who aren't adequately dosed during times of stress. You just can't rely on those adrenals to help out. All right, time to finish up with diagnosis and treatment. Recall that primary adrenal insufficiency should be relatively easy to diagnose. In this version, you have low cortisol because your adrenals are shot, with a corresponding high ACTH from the pituitary. In secondary and tertiary disease, remember, the pituitary is also inhibited. So you should measure a low ACTH. An additional confirmatory test you should be familiar with is the cosyntropin test. Cosyntropin is a synthetic form of ACTH, represented throughout the scene by that action clapperboard. This time, it's held by the cosyntropin co-director. After administering cosyntropin, the serum cortisol is measured at 30-minute intervals. In primary adrenal insufficiency, the defect is in the adrenal glands themselves. So expect no rise in cortisol. There's no waking up the adrenal from a Saturn crush injury to the midsection. Primary adrenal insufficiency at this point is confirmed. In secondary and tertiary adrenal insufficiency, cortisol levels would, in fact, rise after providing the missing ACTH. Remember, it's somewhere above the adrenals that's malfunctioning, not the adrenals themselves. Granted, in the setting of chronic steroid use, adrenal atrophy can occur, so it might be a bit sluggish to respond. As we mentioned earlier, treatment of chronic adrenal insufficiency of any cause is usually accomplished by replacing naturally produced cortisol with exogenous corticosteroids like hydrocortisone. The goal is to replace both glucocorticoid, aka cortisol, and mineralocorticoid, aka aldosterone, activity. Steroids come in many shapes and sizes and have differing levels of mineralocorticoid and glucocorticoid activity. Daily doses of hydrocortisone is regimen of choice for Addison's disease because it provides the Goldilocks level of mineralocorticoid and glucocorticoid replacement. And that's a wrap. For our next scene, we're going from the golden age of film to the golden age of video games. Because it's time to talk about adrenal dysfunction in kids, specifically congenital adrenal hyperplasia. Feel free to insert the Konami code now for Infinite Health. You're going to need it.